Hello and good morning. My name is Jacob McKnight, and today I'm going to be sharing with you a little bit of my research from my DPhil at Oxford Side Business School, where I studied healthcare reform in Ethiopia, and I looked specifically at how it affected hospitals. The title of today's presentation is the Afro-Corporatist Model of Healthcare Reform, and my email address is there, jacob.mcknight@ndm.ox.ac.uk. Equally, you should know that this is a presentation for the Oxford Africa Health Systems Collaboration, which is a new group at Oxford. It draws on a large-scale, very long-term project in Kenya, based in Kilifi on the coast and in Nairobi. And it's also hoping to draw together lots of the resources that are available around Oxford University to extend health system strengthening studies in Kenya and elsewhere in Africa. Please do get in touch if you have any questions about today or about the group. So, beginning then, looking at this image in the center of the screen, you'll see something which is quite important to the theme of today. You see a poster which is produced by the Ethiopian government, and this is on their central square in Addis Ababa. It's a very important square, and it shows a lot of the things that the modern Ethiopian government is very happy with and very proud of. First off, on the right there, you'll see a large satellite dish. They're very proud of their new telecommunications network, which provides pretty decent mobile phone coverage across the country. Equally, you have the Ethiopian Airlines Dreamliner going past in the sky there. Very many people in Ethiopia are proud of that because, of course, it's one of the first airlines in the world to get the new Dreamliner. Equally then, you have new buildings. These are some of the new Kabeli building houses in Addis Ababa, and a lot of the new road network is visible there as well. So all of these images, and especially combined, are descriptive of the modern Ethiopian government's sense of itself, and it's very much celebrating a lot of these new and technological, advanced, modern interventions they've made since in the last 5 to 10 years, I'd say. Of course, and this is why it's important for today's theme, while the government's very proud of these images and these kinds of project, it has left some people behind, and this is more or less what I find for the health system. There are people like the gentleman in the foreground here who don't have access to those to that new modernity. So beginning then, I should explain that the thing that I'm most interested in, the phenomenon that I'm most interested in, is often termed new public management. This is basically the use of business ideas within the public sector. And it's been very popular in Europe and the OECD for at least 20, 30 years now. It has its origins in New Zealand, in the UK and Australia, but then you also see it in Scandinavia and across continental Europe in some form or another. And basically, again, it's this idea of using business ideas such as corporatization or pseudo markets or any one of these things in the public sector to try and make them more business-like, more efficient, more answerable to an imagined consumer of some kind. In terms of the results of this type of reform in the OECD and more broadly, in fact, the results are what one academic termed perplexingly equivocal, in that they don't seem to show a big impact one way or another, despite a lot of the rhetoric that often accompanies the reform about it being a huge and very important step change for the way that services are delivered. But this doesn't seem to be the case when it's actually measured. So what is going on is one of the topics that the Western researchers of new public management like to focus down on. So my research questions are, what happens to reforming public sector services at the micro level? So at the level of service provision, how do these reforms affect what kind of services that citizens or consumers of those services receive? And in the specific case of Ethiopia, how do these changes affect patients? How do they affect users of hospitals? The reforms I look at are focused on Ethiopian hospitals, and the consumer in that sense is the patient. Of course, looking at Ethiopia, there's lots of contextual differences that need to be noted, and these broadly are relevant across the continent, I would say, and they're certainly worthy of discussion more broadly than Ethiopia. So let's just walk through a few of those. Firstly, you have the lack of organizational capacity in the reforming departments, and I don't just mean by this the lack of actual managers in the place, but rather the whole infrastructure of civil service in Ethiopia, and I'd imagine elsewhere in Africa, is much weaker than elsewhere in the world. And as a result, the local oversight, any kind of managerial reform managerial oversight from the centre, upkeep, civil society, these kinds of things is lacking. Of course, you've got lots of development actors. By this I mean donors, NGOs, charities of different kinds, religious groups, and so on. They tend to be a very important voice in when it comes to reform of anything in Ethiopia. And in fact, for the health system, external monies make up about half of the spending in the Ethiopian health sector. So very important. Again, of central significance is the fact that services have no history of accountability towards users in Ethiopia and elsewhere in Africa. The government hasn't really drawn on the idea of its citizens as consumers of services it provides as a business or as an organization which is responsible for providing those services. And so so the users of services are somewhat surprised by this, to varying degrees, as I'll show, are somewhat surprised by this new way of in which they're being seen. And then, of course, the users themselves, the patients in this particular case, have many more problems than they would in the West. There's a much higher burden of infectious disease. They've got much less money to spend on treating that disease, and then even just problems of traveling and so on are really quite significant. Add into that very strict class divides in Ethiopia, at least, and weak democracy. The Ethiopian government is not, I would say, in my personal opinion, corrupt in the way that some African governments were through the 80s and 90s, but they are autocratic. They do have a very strong sense of themselves. And this means that democracy isn't as strong there as it is elsewhere in the world as well. Now, why Ethiopia? Why are we looking at that country in particular? Firstly, it meets a lot of those contextual differences, the list of contextual differences I just gave, which I think are relevant to elsewhere, but really very pronounced in Ethiopia. And secondly, they've really seized the NPM bull by the horns. They've got 3 separate reforms, all of which are very much recognizably new public management oriented. The first is business process reengineering. This is very much a Western, actually a business reform. Its origins are in the corporate world, and so you had GE and lots of other big companies like Caterpillar and others applying this type of technique to reimagine, to redesign their internal processes. Then you have healthcare financing. Healthcare financing is much more akin to some of the structural adjustment programs that happened in the past, but you could say that it's a lot more subtle. It imagines that Ethiopian hospitals will now become responsible for their own cash, so they have to generate profit within the hospital to then spend within the hospital. It also imagines outsourcing to other businesses, private wings for richer customers, richer patients who want to pay for extra care. You also have a fee waiver system, which is meant to protect the poor, but I'll get into to that in a little bit. And yes, like I say, very recognizable, but it is a little bit more subtle than the structural adjustment, perhaps in terms of corporatization rather than full privatization. And the final reform is perhaps the least NPM of the 3, but still holds to many of the NPM ideals, and so it's included here as well. It's mostly a technical document used to improve clinical care in Ethiopian hospitals, developed between Yale University in America and Jima University in Ethiopia. And it's grounded contextually in lots of experience that people had to draw together that document. But it still imagines a hospital CEO rather than the manager, and it still understands the hospital as having to produce cash in order to maintain healthcare provision. And with these three different reforms, you have they all went on more or less at the same time, so they all kind of overlapped. You had a real theory building opportunity, because what existed previously didn't look like that. It was very it was a very neglected health system for a very long time. It was very much underserved and undermanned, but it worked to a kind of centralist, the Ministry of Health being the kind of the central organizational force in the health system. And now they've really tried to change that by decentralizing right down to the individual hospitals. So there's a great opportunity here to build theory. How does NPM, how is it imagined, how is it used, how is it applied in this very different context on the ground? Lots of new public management studies tend to be from 10,000 feet, and I was really interested in understanding what happens inside the hospitals who are asked to implement these reforms. So my methods, I've been to Ethiopia a lot, and especially to Oromia, the most populated region, which is also a large central region in Ethiopia, and I know that region well. I looked at 3 hospitals in particular. Adama is of the highest level, a referral hospital. Ambo is the kind of middle level hospital that I looked at, and then there's Dedir, which is a very remote hospital, very high altitude, and a little bit more difficult to manage as a result. My techniques are ethnographic. Although I'm not really an anthropologist, I tend to use ethnographic interviewing. I combine them with observation. I feel that participation in any sense would be very difficult in an Ethiopian hospital, for me at least. And what I'm trying to do is to get people to talk about their experience of the reforms, to use their own terms, their own framings to discuss reform. I don't want to just go in and ask a series of questions that make sense for me and then have someone else challenged to give good responses to those questions. Instead, I want to try and capture this story of reform from each of the people that I interviewed. And I interviewed the hospital CEOs primarily. They're very important because they're the leaders of reform. And they're also subject to a course, a master's in hospital administration run by Yale and GMO universities that taught them about the blueprint and lots of other new public management reforms. I also spoke to the workers who are asked to apply these logics in their day-to-day lives, and finally to 85 patients who experience change over time. And yes, the extended case method was my overall kind of framing for this. It was an approach used to build theory over time from ethnographic data such as this. My findings then, moving on to the Afro-Corporatist model. This was the eventual theory that I came up with, and it's an extension of some Western theory, but it's very much made relevant to the context, very much based on the experience I had in Ethiopia specifically. And it has 3 elements. The first describes how hospitals become organizations. The second describes how bureaucracies become markets. And the third, how patients become customers. And as I'll describe, for me, these are the main jobs of reform. This is the main work of reform. The managers I spoke to, the workers I spoke to, the things that they tried to put in place, the effort that they went to was mostly to bring about these changes and not to improve overall clinical care. And so if you go back and think about the perplexingly equivocal results of new public management, I think this is potentially why. It's because a lot of the resources, a lot of the efforts of managers and workers goes into these things rather than into improving outcomes. And so firstly then, how hospitals become organizations. Previously, hospitals were what you might call arenas in Ethiopia. This is a phrase used by Brunson and Salen Anderson in a really cracking paper discussing new public management in Scandinavia. For them, arenas are quite different from organizations. Arenas have a very different hierarchy. They tend to be managed by professionals who look elsewhere for their leadership and for their expertise. So if you think of doctors and surgeons, they don't tend to look up towards hospital management, but rather up towards more senior doctors and more senior surgeons who are probably in the center. Probably in the capital or something like that in the universities. And so you get this very different sense of hierarchy. Equally, the borders of the boundaries of the hospital or arenas are much more open. This is for patients and for staff who don't think of them as distinct, cogent organizations, but rather as elements of a national health service that you can drop in and out of, that you can make use of when you like. They speak more to the central power than they do to local management. And of course, in this sense then, when hospital managers, these hospital CEOs, are sent out to Ethiopian hospitals and they encounter this sense of hospitals being arenas rather than distinct, well-organized, hierarchical organizations, they realize that they're not going to be able to manage them, that their own job role isn't suited to this notion of arenas, and thus they spend a lot of their time trying to construct or make organizations. And the three ways in which they do that are firstly by identity. They do this generally by doing marketing within the local area, the catchment area of their hospital. They speak to the local kind of administrations and they say the hospital's under new management, please don't treat it as you did before. They give out flyers saying more or less the same thing to the local people. And very often this is a very physical thing as well. They put up new boundaries to the hospital and make sure that the area that the hospital owns is very well delineated. They do stock checks to count all of the things that they own. It's no longer just government equipment, it's the hospital's equipment. So these are all aspects of trying to create an identity for the hospital. Secondly, they try and set up a new kind of rationality. They simplify a lot of the processes within the hospital so as to be more understandable by a senior level of management. So again, one of the ways that BPR did this was that it simplified a lot of the disease codes that you could use on forms, that doctors could write on forms. And it made it very simple for managers to read. But of course, doctors complained because they felt that they didn't have the level of detail that was required. So this new rationality is very important. And then finally, hierarchy. For managers to assert themselves in these environments, these new environments. And invariably, they were sent from other areas. They weren't known to the local area. And so they had to establish themselves as being at the top of a hierarchy. And the way that they did this was by using access to education. So one of the main advantages of being in the public sector and not the private sector in Ethiopia is that as a worker, you can get access to education. You can improve your abilities and skills as a doctor or surgeon or nurse. And the hospital CEO made sure that they kept a tight control over who got access to education, and they used different phrases for this. So if you were adhering to the reform and you were listening to BPR and using some of the language of BPR and of healthcare financing and seemed to get it, then hospital CEOs generally tended to refer to these staff as being poorly motivated in the past. But now that they were there, they were adequately motivated, and so they were, inherently good staff who just needed a pointer. Whereas for staff who were less keen on the reforms and who didn't pick up on this new language of BPR and the new hierarchy that the hospital managers had brought about, they were denied access to education, and they were often termed as being floaters within the BPR language, which means that they don't lie within any particular process, that they're not useful to a process, and clearly external to the main work of the hospital. So they were alienated in all kinds of ways. So in these three different senses, hospitals became organizations through identity, rationality, and hierarchy. And these are terms used by Brunson and Sal and Anderson to describe this in the West as well. But moving on, something else that I thought was quite central to the reforms as I saw them in Ethiopia, we also saw how patients become customers. So previously in Ethiopia, patients regarded hospitals as an aspect of government. You could go along, anyone could go along, and they'd get some limited care, provided up to the means of the local hospital, and you didn't expect much, but you knew that you would get perhaps something, and so it was worth going along, no matter what your class or what your monetary situation was, your financial position was. When the managers came in, though, again, they needed to change this. They needed to make money under this system, and so they needed to turn a morass of patients into money-making customers. And they did this by encouraging customer ownership within the community. So first off, they looked at, again, some of these marketing efforts. They had big events at the hospital to say that it was under new management, and said, look, you know, this hospital belongs to you and you belong to us. If you're, this is a community asset, but you need to support us. You need to pay for services, and you're going to get a higher quality service as a result. Of course, they did this. They monetized the services not long after, and they did this. Well, there's three important aspects to this monetization of services. Firstly, formalization. So previously, lots of different types of service, but only a few different prices. And so services, rather CEOs, realized there were too many services to too few prices. So as a result, if you wanted to get an X-ray, it was the same price for doing a finger X-ray as it was a full chest X-ray. But now the X-ray price met the cost of providing that X-ray, and it was very different to the cost of providing an X-ray for a broken finger. The rationalization, which is a logical continuation, sees the right price attached to every service, so that hospitals were no longer making a loss on certain services. And then finally, variegation, and this is where things get interesting. Hospital CEOs started to realize that there were certain services on which they could make a lot more money. So radiology, surgery, high-end physio, and the services provided by rare, skilled doctors, they were all very expensive services, and they made a much higher profit. So they variegated services by the ability of the people to pay for those services. And that's what we term filtering. So they started to look at customers differently as by their ability to pay for high-end services. So you have customer ownership, monetization of services, formalization, rationalization, and variegation, and then finally, as a result of these things, filtering of patients. And then finally, the third aspect that I want to explain is when bureaucracies become markets. So obviously with the CEOs concentrating on high profit services, this tends to lead to hospital CEOs targeting specialists who can provide those high-end services. In Ethiopia, unfortunately, there's a real lack of skilled staff. The Ethiopian government is currently spending a lot of money on training staff, but there's no way they'll manage to keep up with the demand of 85 million people, which is the population of Ethiopia, of course. So instead, you have, I think, 150 or so CEOs looking for a very small number of specialists. And as a result, they compete for staff. So whereas previously staff were allocated and there was some personal kind of direction through that about where doctors went when they graduated, where different specialist staff went, now you have CEOs competing for these staff and offering them all kinds of top-up fees for their salaries, very few errors, and perhaps more problematically, they also tend to overlook poor behavior or negligent behavior by medical doctors. So it's very common not to have the doctor within the ward in Ethiopia. They'll come in perhaps in the morning and then go back to their private clinic where they see people outside, and then they come back in towards the end of the day into the government facility. And CEOs can't do much about this because there are so few medics available. And again, yeah, as a result, you see the staff exploiting this, and it's very common for doctors to move around very quickly. They're not held to any one place by contract law, and so they tend to move on to whoever's offering them the best package. As a result, CEOs describe the compromising and lobbying and begging they need to do with their doctors. And so when you look at these three different aspects together, you tend to see virtuous and vicious circles. In the urban centres, the referral centre that I mentioned at the start, Adama, that the reforms have done reasonably well there, because with the investment that the reforms have brought about, and the fact that Adama was one of the first hospitals to apply these new reforms, they managed to put in lots of new successful services. They really cleaned up the hospital. It looks a lot nicer, and you have happier staff, etc., etc. And it's also a rather rich area, so for these higher-end services, there's lots of patients who are willing to pay for them, and then the hospital's making more money, it has more money to reinvest. And so that all makes quite a lot of sense. For rural areas, whereas, what you tend to find is that the CEOs have the same model in mind. They want to add these new specialist services and have their patients pay for them. But because they're usually rural areas, and as I said, for dead areas on top of a mountain, it's rather hard to access. It's much harder to convince doctors and specialists to come out to this area. And of course, this area has many fewer what I call natural resources. By this, I don't mean gold or oil or anything like that, but I mean roads, mobile phone signal, internet, bars, cafes, friends, opportunities for education, opportunities for culture, these kinds of things. So as you'd expect, equally in the West, it's harder to find people to work in rural areas very often. And as a result, the hospital CEOs tend to use the few resources they have to attract these doctors to come to their area. They put in these new services, but then the local patients can't afford to pay for them. So the whole system kind of breaks down. So I want to go briefly into the different types of customer that you see, the different types of patient that you see in Ethiopia. And as I mentioned at the start, I spent quite a lot of time interviewing these patients as well, and trying to understand what I call their consumer journey, all of the steps they went through to seek care. And really, again, this open interview approach worked quite well, because I got whole stories that people told me about their visits to the hospital. And when people had more severe problems, you really got a lot of insight into the difficulties they had in maintaining access to health in such poor areas and under these conditions that the reform have brought about. And very basically, I started to see certain differences in the kinds of story that we're told. And I took some very basic demographic data as well. And there became quite clear splits between urban, rural, and rich and poor. And I think there's some really novel aspects to particularly the rural patients that are quite novel here. So I'll briefly jump through this. This gentleman here, upper urban patient. He's very wealthy. He's got his own home. He is well-dressed, good access to services, and moreover, he understands services. Being well-educated, he's quite used to dealing with people, and sees the doctors as peers. So he has a better knowledge of the health system, and travels easy because he tends to live in urban areas anyway. He doesn't spend much money on the hospital, and you'll tend to find that they're very good at people within this group exploiting the public hospital change, because they can use the public hospital for the aspects that it does better or cheaper, but then go and get private care as well. Then you have the urban lower class. These guys are standing in front of a Kabeli house. It's like a house provided by government, and they'll rent that for about $50 a month or something like that. As I recall, this gentleman was a carpenter and earned a couple of dollars a day, a few dollars a day maybe. The mother didn't work, or I think she sold some stuff at the market. And then there was I think there was a third child inside the house as well. So not very much of an income to look after 3 kids. And yeah, again, these guys tend to be a little bit more careful. They tend to watch the disease worsen at home rather than seek care immediately. It's very difficult for them to raise the cash required to access care to begin with, so they do a lot of loaning and begging. They've got very limited choices about where they go, and tend to go to the pharmacy rather than to the hospital, because you can get some cheap drugs at the pharmacy. But then eventually, when they do reach the hospital, the staff are quite callous. They're quite uncaring because they recognize these people as poor, as not able to pay for the kinds of services that the hospital CEO and the reforms want to give. And as a result, they get quite a bad experience. Now, this family is an upper-class rural family, and they're very interesting as well in that they have a lot more money these days, whereas previously they would have had a lot less money than the upper urban contingent. Because food prices have spiked quite a lot in Ethiopia, they actually have quite a lot of money to spend. But they have very many fewer experiences of this type of system. And so they tend to be quite badly exploited. And what tends to happen is that they first off go to private clinics because they want to get back to their farms. They're very much missed, and it's very expensive for them to travel and then to stay in hotels and eat food away from home. So they want a quick, very effective treatment. So they go to private health systems because they treat them better. And they perceive the quality that they receive to be much higher, although this is not the case. So what you tend to find, one example of this is that lots of people in this segment get given X-rays. They demand them for one thing. They have a real respect for X-rays, and private clinics are too often very happy to give them X-rays. They charge them more for them, and the patient in this case is happy because it looks very advanced, very scientific. It looks like they got a good intervention, got their money's worth. Of course, unfortunately, this is very immoral malpractice by doctors, and it doesn't really help them. So they tend to burn through cash very quickly, buying tests and drugs they don't need. And then eventually, when they burn through their costs, they eventually fall into the public health system, which is cheaper. And when they do reach that, they're disrespected and called ignorant and these kinds of things. And then finally, the lower class rural segment. And what's notable here is that these guys don't tend to make it to the tertiary healthcare. They instead stay in the periphery. They don't ever get much higher than clinics. They don't have the money to pay for it. They don't have the assets to borrow cash to go and seek care. And again, they're very interesting in that if the Millennium Development Goals are to succeed, if we are to work on infectious disease control, to treat infectious diseases, it's this segment that we're really going to need to work on. But they're unaware of how to travel. They are very fatalistic about their treatment. And unfortunately, the fee waiver is completely inoperable in all of the hospitals that I visited. And even if it were operable, they wouldn't know how to use it. So yeah, they're in a very poor position, and they're completely overlooked by the hospital reforms, despite the fact that the hospital reforms are said to be altruistic, they're said to be charitable, etc., etc. And of course, in this case, they're not. So to conclude then, I wanted to look at the effects of reform at the lowest levels, and there are some positives. You do have this new cohort, this new cadre of management going out to very neglected hospitals and giving them some leadership. They improve the functionality of the hospital, they buy equipment, the staff are happier, and they make the periphery more legible. You can see what's going on at the periphery because they're reporting, they're recording, and they're learning. But then, of course, the negatives, and many of these I've discussed, the costs are too high. You get this differentiation of patients, which is really negative. They've got no incentive to help the poor at all. And as a result, they have very much the wrong priorities. They're targeting the upper urban class patient, and they really make that their ideal patient. And unfortunately, it's the other three segments that need the most care or the most help. And so finally then, I want to take you through some ideas I've had for what might be done in Ethiopia in particular, and what could be done to improve new public management interventions elsewhere. Basically, you need to be very sensitive towards poor people and how the reforms will affect them. As I've said, there's lots of positives as managers come into these areas that were moribund and looked past by many administrations. So that's very much a positive. But because of the ideals of the reform, they tend to focus on the richer patients, and you need to be aware of that. So instead, setting up targets for the fee waiver to make sure that poorer people get certificates. Of course, that then necessitates that the levels of administration who are responsible for administering those systems also get an allocated budget for that, plus oversight from a higher level to make sure that that's happening. Because again, in general, they're not particularly interested in poor people either. Regulation of health markets is a really key area. As I described, at the moment, you have private health system clinics providing x-rays and other tests that patients don't need, and there's no real oversight of what they're doing at the moment, and that's partly why that happens. In terms of my own techniques for interviewing people, I tended to talk to people as they were kind of milling around the hospital areas, and doing that, you encounter lots of people who are considering leaving the hospital, who have run out of funds, and they could be from any group. They could even be upper urban patients who've really exhausted all of their funds, and they're actually leaving. And very often I heard things like, we'll go home and we'll pray to God, or we'll go home to die. You could capture some of those exiting patients and really make a difference, I think. You could also target community-level interventions to make sure that some of these patients who don't have access to transport, who expend a lot of cash on getting to the hospital in the first place, paying for hotels, paying for food, etc., that these people are referred to the hospital and thus get some kind of budget or provision to ensure that they can do that. And then finally, and this, if you were, if I were the boss, if you were to ask me what would be the one thing you change, you should change the model. New public management, the idea of these hospitals as businesses is not a good one. It may inspire this new cadre of management, but who's to say that you couldn't inspire them via different means by giving them a different model to pursue? Unfortunately, I think a lot of the results of this new public management reform in Ethiopia are fairly tragic, and recognizably so when you go to the hospital level. Hospitals aren't businesses, and a different logic's needed. And then you could use a lot of this enthusiasm, a lot of this positive energy, and a lot of the better elements of the reform to really push things forward. But having them pursue profit, having them pursue the richest patients is really not what's required for Ethiopia at this time. And so finally, then I should remind you that this was a presentation for the Oxford Africa Health Systems Collaboration, a new group at Oxford University. You will be able to get more presentations like this online sometime soon, but please don't hesitate to get in touch with me at my email address here, jacob.mcknight@ndm.ox.ac.uk. Thanks very much.